the bradyarrhythmia. We'll go very slowly. And it's not very complex to understand like arrhythmias, tachyarrhythmias. We'll finish off with that. So the next aspect of arrhythmia is a bradyarrhythmia, where the heart is beating slowly. And remember the sinus rhythm. In a bradycardia, bradycardia, the heart rate is less than 60 per minute. The commonest arrhythmia is sinus arrhythmia. Please remember, this is a commonest arrhythmia in children especially. In sinus arrhythmia, the heart rate quickens in inspiration and slows down in expiration commonly in children, which is called phasic sinus arrhythmia. So whenever the heart rate changes with the respiration, it is called respiratory sinus arrhythmia. If the spontaneously the heart rate is slowing and becoming fast, it is called non-respiratory sinus arrhythmia. So the faster cycle and slow cycles are going on. The commonest arrhythmia in children, the heart rate is faster in inspiration and slower in expiration. It does not require treatment. The AST abolishes the sinus arrhythmia in children, and right corner disease produce sinus arrhythmia in adults. So in simple terms, the presence of sinus arrhythmia in adult is abnormal. The absence of sinus arrhythmia in children is abnormal. So absence of sinus arrhythmia produced by large AST in children. The presence of sinus arrhythmia is produced by RCA disease. Why RCA disease? Right coronary supplies the sinus node. So when the sinus node becomes ischemic, it fires irregularly, and it is not related to the respiration. So most often adult sinus arrhythmia is non-respiratory. Children's sinus arrhythmia is respiratory. So please welcome, sir. Welcome. So you can see that the heart rate is quickening and becoming slower in inspiration and expiration. So this is, we welcome Dr. Rajan, the former Dean of Stanley Medical College. So bradyarrhythmia classification is very simple: disorder of impulse formation and disorder of impulse conduction. If the sinus node is not forming an impulse, it is a disorder of impulse formation. Sinus node forms the impulse and the impulse is not reaching the ventricle, it is a disorder of impulse conduction. Example of impulse formation is sinus bradycardia. In terms of impulse conduction is atrioventricular block. Here the sinus node forms the impulse, but the impulse is not reaching the ventricle because of atrioventricular block. Sinus bradycardia, the sinus node is forming the impulse at a lower rate. So you have the heart rate less than 60 per minute. Commonest cause of sinus bradycardia is athletes during sleep, right coronary disease, hypothyroidism, hyperkalemia, and commonest cause of sinus bradycardia is ourselves: digoxin, beta blockers, calcium blockers, and intracardial tension. So just like I told you about sinus tachycardia, in sinus bradycardia you always find the cause rather than jump to treat a sinus bradycardia. The treatment, the diagnosis of sinus bradycardia is all the criteria for the sinus rhythm is fulfilled except the rate is less than 60 per minute. All the other criteria is there. Then you must understand a pause. A pause is a situation where the QRS is not found. The heart forgets to produce a depolarization. That is your pause. So the pause is a period in which there is no QRS, is called pause. So this is a pause. So suddenly you can see that beats are coming. Suddenly there is no beat coming. This is a pause. So if the P is not coming at the next expected place, or the P is not followed by the QRS, there are two reasons for a pause. Inside the pause, the P itself is not happening, means the sinus node is not producing impulse. Whereas if you have inside the pause, if there is a P wave which is not followed by QRS complex, you know, sinus rhythm has produced an impulse, atrial depolarization has happened, but that is not going to the ventricle. So here it is a disorder of impulse formation, here it is a disorder of impulse conduction. So any pause you have to differentiate between these two. So you can look at these two examples. Suddenly there is a place in which there is no QRS, but inside this pause you do not have any P wave. That means no sinus rhythm activity at all. So this is what pause? Sinus pause. Here the sinus node is not producing an impulse. This is a disorder of impulse formation. Whereas you can see it here in this pause, there is a P wave which is occurring, but it is not followed by QRS complex, means sinus node has produced an impulse, atrial depolarization has occurred, but this is not going to the ventricle. So that's why inside the pause, if you look for blocked P waves, if it is present, it is an AV block. If there are no P waves, it is sinus pause. Is that clear? Now we go and see what are the types of AV block. Sinus pause. So another example of ECG, you can see the pause here. Suddenly you have a long period in which there is no QRS. Here there is a P wave there and it is not followed by QRS complex. So what pause this is? This is atrioventricular block. So atrioventricular blocks are divided into three types. One is first degree atrioventricular block, second degree atrioventricular block. There are two types of second degree atrioventricular blocks, type 1 and type 2, and there is a third degree atrioventricular block which can be a Supra-his variety or an Infra-his variety. So in first degree heart block, all P waves are conducted with the delay. In second degree atrioventricular block, some of the P waves are conducted with a delay, and in third degree atrioventricular block, none of the P waves are conducted to the ventricles. So the ventricles are governed by either a secondary pacemaker like junction or the ventricle. So first degree, all P waves are conducted with delay. Second degree, some are conducted and some are not conducted, whereas in third degree, none are conducted. So first degree atrioventricular block, you will have all P waves are going to be followed by QRS complex, but with a long PR interval. What is the normal PR interval? 0.21. So more than 0.21. The first degree atrioventricular block, the importance is whenever it is isolated. So whenever you have a long PR interval, two things you have to see. One is whether the QRS is normal or abnormal. If the normal QRS, the prolonged PR interval most often may not require any treatment, but you must carefully look at the drug history. Many times the drugs we use like amiodarone, beta blocker or verapamil or digoxin is producing the prolonged PR interval. So first go into the drug history. When it is isolated first degree atrioventricular block, you need not do anything. But the importance is when it is associated with, what is this? Right bundle branch block. So whenever the PR interval is associated with what two things? Right bundle branch block or left anterofascicular block. I told you how to diagnose a trifascicular block. Right bundle branch block, fascicular block plus prolonged PR interval. So whenever the PR interval is prolonged in the presence of a bundle branch block, it indicates an advanced conduction system disorder. You must be careful. So this is the importance of first degree atrioventricular block. Second degree atrioventricular block, some P waves are conducted, some P waves are not conducted. It is called intermittent interruption of conduction. Intermittent interruption of conduction. There are two types of second degree heart block. Type 1 is called Wenke-Bach AV block, where you have progressive lengthening of RR interval followed by the block P wave, and the importance is the site of block in type 1 second degree atrioventricular block is at the AV node. So here the P waves are getting delayed and the P waves are getting blocked at the AV node itself. So type 1, the block is at the AV node, and most often it may not require treatment. Most often it is a conservative treatment for type 1 second degree atrioventricular block. It's called Wenke-Bach's phenomenon. So here what happens is the PR interval gets progressively prolonged and suddenly you find a P wave which is not followed by the QRS complex. Then PR interval starts normally, then it gets prolonged and then the P wave is blocked. So there is a progressive lengthening of PR interval before the P wave is blocked, which is called Wenke-Bach type 1 atrioventricular block. So how to approach this problem will be, first to identify the pause. First here the QRS complex is here. Here you suddenly find a pause, isn't it? Suddenly you find a pause there. So once you find a pause, see inside the pause the P wave is there or not. Inside the P wave is there. So it is what block? AV block. So once you decide AV block, see some of the P waves are conducted or some of the P waves are not conducted. So this is a second degree AV block. Once you decide the second degree AV block, see the previous PR intervals. If the previous PR intervals are gradually prolonging before it is blocked, if it is gradually prolonging before it is blocked, if it is, you can see that here in this cycle, P wave is blocked here, see the PR interval there, see the PR interval there, see the PR interval there. So before the blocked P wave, if there is a gradual lengthening of the PR interval, it is type 1 second degree atrioventricular block. The block is at the AV node. The block is at the side. Why this is important? Because you want to know where these P waves are getting blocked. The block is at the AV node. Whereas in Mobitz type 2 AV block, you will have no lengthening of the PR interval. The PR interval remains constant and consecutively get conducted. In spite of that, there is suddenly a beat which is not conducted to the ventricle. So it is the block P wave in the presence of constant and consecutive conduction. So if you see the block P wave, if you see the previous PR intervals, they are absolutely constant. There is no change in the previous PR intervals before the block P is type 2 second degree atrioventricular block. So once again you can see that here we first find a pass. First see the regular rhythm there. Here the QRS is not happening. See inside there is a P wave. So it's a AV block. Then see the previous PR intervals. They are absolutely constant. There is no change. That means this second degree atrioventricular block is Mobitz type 2. In contrast to type 1 second degree atrioventricular block, the type 2 second degree atrioventricular block is dangerous. The disease is in the distal conduction system, in the bundle branches and vesicles. Most often, this will predispose the patient to complete heart block and Stokes rhythm attacks. So most often type 2 second degree atrioventricular block requires a pacing, the disease in the conduction system, distal conduction system. Type 1 second degree always at the AV node, usually benign, self-limiting, rarely progresses to complete heart block, usually associated with inferior valve myocardial infarction. Whereas type 2 second degree atrioventricular block occurs as a distal conduction system, more severe disease, progresses to complete heart block and Stokes rhythm, most often it requires a pacer. So that's why the importance of diagnosing whether it is a type 1 second degree or type 2. So the steps are identifying a pass. Inside the pass, find the block P wave, previous PR interval to be seen, progressive lengthening of previous PR interval type 1. If there is a constant PR interval, it is type 2. There it is in the AV node, here it is in the distal conduction system. Is that clear? Now we will go for the complete heart block before we go for a complete third block. So at the end we will have a complete third block. Before that we will finish off complete heart block. Right? So the third degree complete heart block is none of the P waves are going to be conducted. See that? All your P waves are going to be blocked either at the AV node or distal conduction system. For the heart to go on, you must have a secondary pacemaker which is coming in. Please remember that. So when the secondary pacemaker coming in, then you have a rhythm which is controlled by a pacemaker differently for the ventricle, and you have a beat, and when you have a sinus rhythm which is controlling the atrium. So similar situation like what? Ventricular tachycardia. Similar situation like a ventricular tachycardia where there is a single, one pacemaker is depolarizing the atrium, one pacemaker is depolarizing the ventricle. Only thing is here it is a bradyrhythm, there it is a tachyrhythm. So here you have an AV dissociation. Atrial rate is faster than the ventricular rate because sinus rate will be faster, but it is not going through the ventricle. Whereas ventricle, secondary pacemaker, rate will be lower always than the sinus rate. So here always the atrial rate will be faster than the ventricular rate. So escape rhythm maintains a life. So you can see that here. So here you can see just I am introducing the concept of supra-his complete heart block and infra-his complete heart block. For example, if the sinus node produces an impulse and the impulse goes through the atrium, depolarizing the atrium and coming through the AV node, and let us imagine all my impulses are blocked at the AV node. Because the impulses are blocked at the AV node, this block is called supra-his complete heart block because the block is occurring above the his bundle. So once the P waves are blocked here, what is the immediate pacemaker available to me? What is the immediate pacemaker available to me? Junction. Immediately the his bundle junction is the secondary pacemaker which is available. So if the P waves are going to be blocked, my junction will take over and start producing the impulse to protect the heart from the complete cardiac standstill. So the junction will start producing the impulse. Once the junction start producing the impulse go through what? Normal conduction system. So this escape rhythm will have what QRS? Narrow QRS. Although you have atrioventricular dissociation, because your atrial will be governed by the sinus node, now the ventricles will be governed by the junctional rhythm, but this junctional rhythm will have a narrow QRS. So if if you have an AV dissociation and the escape rhythm has got a narrow QRS complex, that means your block has to be above the junctional pacemaker. It will be happening in supra-his complete heart block. So look at this ECG, basically a bradycardia, and the first important thing is to demonstrate an atrioventricular dissociation. See the P wave there happening here. It is on the ST segment in between QRS complex, just in front of your QRS complex, happening at the end of T wave. You see, P wave is happening in different portions of your QRS complex. That is your atrioventricular dissociation. Here, the bradycardia and the atrial rate is faster than the ventricular rate, telling you, although the sinus rhythm is producing the normal rate, it is not able to reach the ventricle. The P waves are totally blocked. Then the ventricles are governed by this rhythm, which is also happening regularly, but rhythm has got what QRS? Narrow QRS means it is a junctional rhythm. That means your block has to happen proximal to this pacemaker. That means your block is happening at the AV node. So this is a supra-his complete heart block. So in contrast, if you have a block in the distal conduction system of bundle branches and vesicles, what is the next pacemaker available to you? What is the pacemaker available to you? Ventricle only. So only ventricle has to produce the impulse here, because no longer the junction is there, no longer other vesicles are there, it is the ventricle. So my pacemaker has to arise from ventricle. If the ventricle produces a rhythm, it is going through the muscle, it has got no access to the surfacial conduction system. So this escape rhythm will have what QRS? White QRS. So if your escape rhythm has got a white QRS, you know that it is the ventricle is escaping. That means the block is happening at the distal conduction system. It is happening below the bundle of His. So it is called infra-his complete heart block. As you can see it here, first to demonstrate an AV dissociation. P wave is here, P wave is here, P wave is here. Basically, absolutely no relationship between P wave and QRS complex. Atrial rate faster than your ventricular rate. Then look at the QRS width. QRS is wide. So because the QRS is wide, it is arising from the ventricle. So it is a ventricular pacemaker rhythm in the presence of an atrioventricular dissociation with an atrioventricular block. This block has to be infra-his complete heart block. So infra-his and supra-his complete heart block are decided by the escape rhythm. If the escape rhythm is from junction, it is supra-his. It is from the ventricle, it is infra-his. What is the importance of knowing whether it is supra-his complete heart block or an infra-his complete heart block? In supra-his complete heart block, your site of block is at the AV node. In infra-his complete heart block, it is in the bundle branches and vesicles. The escape rhythm is a narrow QRS escape rhythm in supra-his, wide QRS escape rhythm in infra-his. The rate is between 40 to 60 here. The rate is less than 40 here. It's a stable rhythm in supra-his complete heart block. It is an unstable rhythm because ventricle is not tuned for pacemaking. It is tuned for pumping. So if you ask ventricle to produce a pacing, it will not do correctly. It will not do it stable. So that's why the ventricular escape rhythm is unstable, and stroke-rhythm attacks are more common in infra-his complete heart block when compared to the supra-his complete heart block. Which second degree AV block will precede supra-his complete heart block? Type 1 second degree, because in type 1 second degree we told you the blocks are happening at the AV node. So when it becomes total, if at all the type 1 second degree is going to proceed a complete heart block, it will be a supra-his, which is a stable escape rhythm. That's why we told type 1 second degree escape block conservative management, because if at all is going to produce a complete heart block, it is going to be supra-his and stable escape rhythm, so you do not give an aggressive management. Whereas infra-his complete heart block, you will have infra-his complete heart block, we will have a type 2 second degree AV block will precede, and most common in anterior MI here because of the destruction of the bundle branches and vesicle. More common inferior wall MI because right coronary supplies the AV node. So inferior wall infarction most often produces supra-his complete heart block because the AV node is involved. Anterior wall infarction most often produces infra-his complete heart block because bundles and vesicles are destroyed by the LAD disease. Conservative management here and the aggressive management with the pacer here. Good prognosis here, not so good prognosis here. That's why importance is to diagnose between supra-his and infra-his complete heart block. So this is a summary of all our atrioventricular block. Look at P waves and QRS. If all P waves are conducted with delay, it is a first degree atrioventricular block. In isolation, look for the drug history. When it is with the bundle branch block or a fascicular block, it is dangerous. When some of the P waves are getting conducted and some of the P waves are getting blocked, it is second degree atrioventricular block. So carefully look for the previous PR interval. If there is a varying progressive lengthening of previous PR interval, it is type 1 Ventke-Back phenomenon. The block is at the AV node. It may predispose, if at all, to supra-his complete heart block, in which Stokes-Adam attacks are uncommon. Whereas it is a previously constant PR interval with a block P, it is type 2 second degree atrioventricular block. The block is at the infra-his. SA attacks are common, so you may need to pace at this point itself. When none of the P waves are getting conducted and there is an atrioventricular dissociation, no relationship between the second degree with the P waves and the QRS, then it is a third degree atrioventricular block. Then look at carefully the escape rhythm. If the escape rhythm has got a narrow QRS escape rhythm, it is a supra-his complete heart block. Stokes-Adam attacks are uncommon, conservative management. If it is a wide QRS complete heart escape rhythm, it is an infra-his complete heart block. SA attacks are common, so you have to need a pacemaker implantation. So this is in nutshell your approach to all our atrioventricular block.